Excellent.
All right. Okay, this is a patient that presented, hold on one second. With a history of, or a clinical presentation very consistent with a metastatic tumor. And let me just show you the PET, just to give you a feel initially for the extent of tumor in relation to bone, lymph nodes in the upper abdomen in multiple locations, and some adjacent to stomach. We see FDG avid lymph nodes in the chest in various locations, perhaps pleural surface tumor, very extensive nodal disease. And if you look at the PET in the background, there is clearly a lot of pulmonary parenchymal FDG activity as well. So I will tell you that they did, and I'm not sure the precise nature of the workup, but it did involve endoscopy. And a tumor mass was apparently found right near the GE junction. So I presume somewhere in this location, I'm trying to see if there is clearly an FDG avid lesion that they did biopsy and revealed findings of gastric cancer. So that's the pathologic diagnosis. The patient didn't improve on diuretic therapy. I think the clinical team and maybe the initial interpretation suggested lung edema. The patient did have some renal dysfunction. I don't know how severe. When the patient didn't improve, I was asked whether these imaging findings that I'm going to show you now are consistent with lymphangitic tumor spread. And clearly the answer is yes, very definitely. So there's florid, diffuse interstitial lung edema, particularly in the form of septal lines, peribronchial fluid cuffs, subpleural edema. There's a lot of nodal disease, there's pleural fluid. So my answer was a definite yes. And I think supportive of that, in part, is the fact that there is so much diffuse pulmonary FDG activity. So a biopsy I thought was clearly unnecessary, and I was pretty confident of the diagnosis. Would you all agree?
Yes, I think so. And also, it's not the, it looked, at least initially when you were scrolling through it, that it looks very non-dependent, a lot of it. I mean, it's pretty extensive, but yeah, it seems to have an anterior gradient more than a posterior gradient. And then the other finding that I like, and you mentioned the fluid cuffs, but the veins seem to get very shaggy in patients with lymphangitic spread of tumor. It's probably engorgement of the lymphatics around the veins. If you can find some pulmonary veins, sometimes they look a little bit shaggy or irregular. They're like right in the lower lobes and the superior segments where you just were, there was some nice shaggy veins.
Yeah. Let me just go to the mediastinal window because I wonder, well, I can't tell because it's so grainy, but I do wonder whether some of that is also, and I see that I don't have conventional images, but I wonder whether some of this, well, clearly there's nodal tumor. I wonder how much nodal edema there could be as well. But in any event, I think the findings are very typical. I mean, it's a dire prognosis, but I think the findings are very consistent with diffuse lymphangitic spread of tumor. Pretty classic, I think.
Yeah, nice case. That's so it was. This was the presentation then.
She was apparently initially well and presented very ill.
Wow.
And was diagnosed with metastatic cancer.
Okay.
Yeah.
All right. Well, thanks.
All right, Nick, that's my case.
Yeah. Okay. All right. I'm going to go next. So let's see. This is the case I tried to show last time. And let me load it up here. This is our little kid, and let's show the screen. Let's see. Yeah. So you should. This is the MR. So this is the. This is the right one. Yeah. This is going to be our. Yeah. This is our Digeorge syndrome. So I'll just show the. Let's find the. So here the There we go. So on the T1 images, we can see that there's no thymic tissue, which would be part of the Digeorge syndrome. And here we have the flow images. So this lets us see the vascular anatomy better. So we can see a pulmonary artery, the ascending, descending aorta, and you will see that the aorta here is actually very high riding, and I'll show the 3Ds of this, but so we're going north. So this is the arch. You can see it's a very high riding arch with very funny looking vessels coming off. Then it crosses over and then descends on the left. And the reason the caliber changes is you can see this flow artifact. We've got a patent foramen ovale here, so there's more flow to the descending than the ascending aorta. These are there we go. These are the 3Ds. So we see this high riding arch, and you can see it crosses behind into the descending aorta, and this is your patent ductus right in here. So this is a right cervical arch, which is associated with Digeorge syndrome, as are interrupted aortic arches, circumflex, and that it crosses and descends on the other side with a patent ductus arteriosus there. And I think we had seen a case earlier, so I meant to show it last week, and somehow I only had one series, which did not do a very good job. Oh, I do have some cool flow images I would like to show. Let's see if I can make them load up. So this is using a technique called PC Viper. So this is the 4D flow. And you can see that the color is a velocity in meters per second here. So you can see there's the flow coming up the arch. And so it's a pretty small amount of flow in that aorta in there. And then I've got these images here. You can see again. So this is going out into the pulmonary arteries. I thought I had the other one as well that showed the PDA, but I'm in the wrong plane. But you can do this technique using MR, and often these are done, they require a little bit more time, but using post-processing you can get the flow in some of these shunts. And then here's the radiograph where you see the absent thymic contour, this high riding aorta. The aorta, you see the descending aorta is large, and you don't really see the cervical arch very well. But the absent thymus is typical of Digeorge syndrome. Okay, let's look at this case. This is just kind of a cute case I came across. I was looking at the CT, and this patient has a port in there, a new cancer diagnosis, and this was just for staging. It was, I believe, an abdominal cancer. And didn't see much until I got down here and see this catheter fragment just kind of hanging out, extending from the main pulmonary artery into the right upper lobe, not attached to anything. And we had no previous imaging, so I have no idea how this got there, how long it got there. The presumption was it sheared off this port, but if you look at the port length, it terminates in the right atrium. So I'm not so convinced that that's where it came from. It could be from something else. It's a good sized caliber catheter, so I had no records of any previous instrumentation, so hard to know what that came from. One of our interventional radiologists was able to fetch it, so you can see this is just the video here, and it's kind of cool. They put their little snare in there, send it out, and you watch them grab the catheter, and you see it just folds right over, and they pull it right out. So this is the errant fragment of catheter, and they just grab it, and it's soft and pliable, and it pulls right through. So they're able to remove this there. So little embolic thing there. I wish I had a radiograph. It would be a nicer case, but I don't have one. All right, this is a good case, and this is a great case for the lateral projection. Let me get these in order. So this is a patient who had a transplant. Let me find the oldest radiograph. So here we are back in June, and you can see this patient has had a double lung transplant. It was a young man. I think it was for cystic fibrosis, if I recall, and has some linear opacity, some scar in the lungs, but at this point looked pretty good. And we look at the lateral projection at that time, and we see normal bronchus intermedius, normal hilar area, nothing terribly exciting in there. Then I'm going to put up the next one, which was 6 months later. So I'll put the two frontals up, this one and then this one. And then I'm going to put up one from just last month. And you can see there has been a subtle change, harder to see on the frontal view, but we're starting to see it starting to fill in the right paratracheal stripe. So it's normal on the first scan, and let's see, where's the which button it is. There we go. So you can see June, September, April. And on this last one, this area fills in somewhat, the right paratracheal region. Now I'm going to put up the laterals. So we've got June, December, and April. And there's been a change as well. And if you look in December, in retrospect, I think you can start seeing it starting to fill in a little bit. Thickening of the posterior wall of the bronchus intermedius. And I'll blow that up. There we go. So we can see it's starting to thicken up back in here. And you can see for sure on the most recent lateral, it's filled in even more. And then infrahilar window is starting to fill in as well. So looks like developing lymphadenopathy. Patient was starting to have some symptoms, not doing well. I think had some weight loss. And so this is a CT scan that was done around the same time. And we see paratracheal lymphadenopathy, which corresponds to the right paratracheal stripe thickening. Subcarinal lymphadenopathy, which is accounting for the filling in on the lateral radiograph. And so if we make a sagittal, we can do a ray-sum image. We can see that filling in beginning to start there. And then that thickening of the posterior wall, the bronchus intermedius, is accounted for by this soft tissue back in here. So this got a biopsy. It was presumed to be PTLD. And interestingly, the path came back as classical Hodgkin lymphoma, which can be a manifestation of PTLD. And it was EBV negative in this case, which is kind of interesting, but had all the typical features, Reed-Sternberg cells, and the various markers that they see with Hodgkin lymphoma. So a great case of the lateral really helping you here, especially in that infrahilar window, the posterior, the wall, the bronchus intermedius there.
Yeah, very nice demonstration of that.
We've had a run of good lateral cases, and they're always good ones to learn from because it's very easy to overlook stuff. All right, this is a case, I believe I showed this case a few weeks ago, and we have some follow-up imaging. This, and I may not have shown, I sometimes lose track of this. This is a guy who presented with a neck infection and developed, make sure I'm showing the right thing, yeah, developed some soft tissue infection around the sternoclavicular joint, extending into the upper mediastinum. And so they treated him for that. He had a little bit of fluid around the aorta there. It's just up in the pericardial recess. But at that point, not a lot. The fat here looks fairly clean. Most of this infection was brewing up in here. It was extending down from his neck, so on this neck CT. And he had a chest CT at that time. Yeah, that's the chest CT. But he got a neck CT about a week after that chest CT, following up his neck infection. And you can see they've cleaned him out. There's some drains in there, but there's still fluid and gas in the area. And it does extend down into the upper mediastinum. There's a lot of artifact coming off. But you know, the anterior soft tissue now in the mediastinum is getting a little bit dirty still. But then we go down here and we notice that now we've got enhancing pericardium on this neck CT in that same area around the aorta. And it looks a little bit thickened. The prevascular mediastinal fat is pretty much, it looks pretty normal, but the pericardium down here, you can see doesn't enhance as much as up here. So, you know, a little bit concerning that there may be something brewing around the aorta. And then he had another neck CT just a couple of days later, no other chest imaging at that point, but you know, following up this collection, because there's still a lot of debris in here, pus, fluid, and you can see it's all very angry looking in this area. But now as we come down into the mediastinum, we now see this outpouching that has developed in the course of 2 days in that area. So here's the old one. And you see that the aorta there, you know, this may have been the very, let's see, I got these. Yeah, this is, in retrospect, you wonder if this was brewing right here, but now you've got a full-fledged a pseudoaneurysm, mycotic pseudoaneurysm, from a deep neck infection that extended downward. And then along these same lines, this is another interesting case we had come in. So this is a guy who has aortic stenosis and has a valve that looks like this. You can see heavy calcification, thickening, and some mild, but not horrible, maybe a little bit of post-stenotic dilation, but nothing too bad. But eventually needs to get his valve fixed. He's got some LVH, maybe sort of borderline there. But then he developed fever and wasn't in a stroke, and so they were worried about this aortic valve again. And you can see that now he's developed this outpouching along the posterior aspect there, and then a second one sort of down here. But this one, interestingly, ends up communicating with the left ventricle below the outflow tract. So he's got a sort of an aortic insufficiency, effectively, that the blood comes back in. If I make a coronal of this, I think it'll show up better. So we go back and we see there's your valve, and you've got this pseudoaneurysm that does communicate with the left ventricle. So he had two pseudoaneurysms right at the root there. So he had to have not only the valve replaced, but they had to go resect the root and replace this whole portion in here and clean this out. So this is just not a drug use or anything, but just pre-existing lesion with a stenotic thickened valve, developed endocarditis and the pseudoaneurysms that then was throwing stuff, had the little stroke, and had to get this fixed. And that was just over 2 month periods or 1 month period. So it developed rather quickly. Okay, that is all I have this week.
So Jeff, there was no intervention.
No.
That
no.
At all.
Other than he was getting, he was going to get a workup for a new aortic valve, and they had done the original CT, and he got sick before. He wasn't scheduled for surgery right away, and I don't know if they were just waiting for it to get worse or if he was just putting it off a little bit. But yeah, it's just one of the complications of a bad valve, and somehow got bacteremic, got endocarditis, and so what would have been a valve replacement became a valve and root replacement. All right. Travis is up. And just so you know, Travis is sitting right here with me in Madison this week. He's our visiting professor today, so he gets to do the webinar as our guest presenter.
Right. We have the problem where I'm too close to Jeff right now.
What I can do is, or I can.
I'm about 12 feet away from him.
There, I'm muting my speaker. All right, I'm going to change it to Travis. Here we go.
All right. I know that Jeff can see my screen because I'm looking at his screen too.
I've got us muted too, so you can come sit over here if you want.
So this is a case that recently came in, radiograph a couple weeks ago. You can see this patient has this rounded opacity in the right mid-lung. And they have a catheter, and their history is that they're neutropenic. And I think this is one of the best radiographic examples I've ever seen of this. And here on the CT, Howard, I know you will like
this. We're getting this echo effect, so maybe one of you guys should mute something.
Echo.
Oh, I got to turn off my mic. Sorry.
Maybe turn off your speaker.
Oh, now it should work. Okay.
Perfect. Great.
Yeah. So I think, Howard, you or Jeff was one of the ones that coined the bird's nest term. And I think this is a pretty good example of this. And of course, we always think of this most commonly with mucor rather than other angioinvasive fungal infections. But you also have a little bit of a halo and reversed halo. And this is the central lucent area that looks like a bird's nest. We thought this was going to be mucor, and certainly that's what it most commonly is. And I'll get to the pathogen in a second here, but I think it's a nice example they repeated with contrast. You can just see how the vessels cut off going into this. Now, this was growing while he was on pretty aggressive antifungal coverage. And you can see he does have some other smaller nodules with little halos in the other lobes. But this actually is not mucor. This turned out to be Aspergillus, at least based on their presumptive testing. So they bronched and got a PCR that detected Aspergillus, and he was also galactomannan positive. So I think it's probably a bird's nest with mucor. And I don't know if the presence of all the other nodules argues in favor of Aspergillus as well. Because usually I think of mucor as just being one lesion. Again, it's an academic point. I don't know. Yeah, but this is a good example, and they're planning surgery to resect this because he's got other comorbidities. I guess the one thing I will point out that may complicate this, which I need to discuss with the surgeons, is the fact that this crosses the fissure. It's involving both the middle lobe. As you can see, these are the lateral segmental bronchi of the right middle lobe and the upper lobe. So I don't know if it's an incomplete fissure or if it's actually crossing the fissure here, but certainly they'll need to be aware of that. It's rarely incomplete laterally. It's really complete. Yeah, right. Jeff is saying, yeah. So that's kind of one potential interesting complication from this, but pretty interesting, nice looking bird's nest with great radiograph correlate.
Yeah, one other organism. David showed some cases of a bird's nest with non-Nemophila Legionella as well can present like that.
I think the term bird's nest originated with the European radiology group. I'm not sure, because that's the first place that I saw it was in, I think, a European journal, maybe from some German radiologists. So certainly not mine, but I think they may use that term, at least in some portions of Europe.
Okay. I think it's a very helpful descriptive term, though, for these angioinvasive fungal infections. This is one that my colleague Kim saw over the weekend a couple weeks ago. This is kind of an interesting history. This lady had some lower GI symptoms and some diarrhea, and then she developed, as they described it, like near simultaneously two distinct areas of pain. One was in her left lower quadrant, pretty low down, and then the other one was in her left upper quadrant with some pleuritic chest pain. So she underwent a PE study, and then she had another study that was done just an hour later. But, you know, this was a pretty good pickup on this study that she has a heterogeneous enhancement of her spleen, but it also looks a little inflamed. And the suggestion of an infarct was raised, especially because you see there's a small little splenic artery aneurysm, and it looks like a branch here just is occluded. But of course there is no PE, but going up into the aorta, that you can see that this is not the flow artifact or smoke, but this is a discrete thoracic aortic mural thrombus, or these just aortic thrombi that we've seen on occasion. I think what's interesting about this one is just the origin that tends to be more from the lateral and superior portion of the aortic arch, because usually we think of these arising along the undersurface, but certainly this is a legitimate thrombus in the aorta. So the presence of this and this lower GI pain that she was having as well prompted them to do another arteriogram with completion through the abdomen and pelvis. And of course, on this study, you see that this is still here, and it persisted on the venous phase. But what was interesting is that she actually has two separate processes that are, this is not attributable to the mobile thrombus, but she also had acute diverticulitis, and you can see an inflammation here, and it looks like probably this diverticulum here is the one that's inflamed. But it's kind of interesting that these were true and unrelated. So she's on antibiotics and anticoagulation. And I will say that one of the other reasons that that just reminds me, one of the other reasons that the CTA was prompted, because I think it was a legitimate concern about her having mesenteric ischemia, given that she had a potential source of thrombus, was the fact that she had a little bit of portal venous gas seen on the original study too, which was certainly a scary finding. But it looks like these are unrelated. Now, these are still certainly controversial in terms of management. Will this resolve with anticoagulation? Do you go in and resect them? Smaller ones we've seen covered with stents. So we'll see. The jury is out on what will happen with this thing. But it's another example of a aortic arch thrombus. So, All right, let's see what this one is. I need to remember. This is a patient who, so I don't think there's any really much on this radiograph. And this is a young patient. And I'll put these up side by side just to see if anybody else has any, if you guys have any thoughts. And clearly now she's developed left lower lobe collapse a month later after this prior one. You can see it looks like there's something in the hilum. And even when I show you on the lateral views, maybe in retrospect, you say there's some cutoff of this left main stem bronchus, but even on the lateral view, you'll see that it's not really that convincing because you can still see her left main and upper lobe continuum right here. So anyway, 22-year-old that comes in as an outpatient now with collapse, considerable amount of volume loss, and she undergoes a CT. And of course, this is just a differential diagnosis, but you can see how proximal this lesion is and how enhancing it was. And I showed recently a case of a mucoepidermoid tumor. This is in the left main stem bronchus, kind of right at the junction with the trachea. So carcinoid tumor, given this vascularity. And then, best case scenario is she has inflammatory myofibroblastic tumor, or something else. And actually they were able to resect most of this endoscopically, and this did turn out to be an inflammatory myofibroblastic tumor. So best case scenario for her, they didn't have to do any surgery and her lung is re-expanded, but just differential case because it's kind of proximal for a carcinoid. I don't know if you guys have any other comments, but yeah.
I'm trying to think if I've ever seen a case of an endoluminal IMT in the central bronchial tree. I don't think I have. I can't recall.
I thought you've shown one of I mean, we've seen them in lobar bronchi, but I don't know when the last time I saw one was.
Yeah. IMT are usually large at presentation, usually large pulmonary masses, right? Usually.
Yeah, I don't recall seeing one of these in the airway. The ones I've seen are big lung masses.
Wow.
So I think I've seen one or two that were in the airways more peripherally, but usually it's diagnosis of exclusion and it's just on path. But yeah, I don't know. Jeff made the comment that it's centrally very low attenuation. The rest of it's hyper enhancing. So, but again, just differential. Now here's another one. I think the radiograph is interesting and instructive in this case. So this is another young patient about the same age who also comes in, and these are a couple, let's see, these are 2 weeks apart basically. And you can see, at least on the original one, he has more volume loss on this side. It's kind of like the equivalent of right middle lobe collapse, I think, because you're mostly just losing the left heart border. And there's maybe a little fullness in this left hilum. And then on this repeat 2 view, you still see some obscuration of the left heart border in this case, and a little bit of opacity here more proximally. Now in him, though, you can see, again, looking at the lateral, like Jeff was just talking about a few minutes ago, here you see the intermediate stem line. So you see stuff on the right, but you don't really see your expected left-sided structures. You see a little bit of the left pulmonary artery, but none of the left, or not much of the left main upper lobe continuum. So he had 2 CTs, one at each time here, and they both showed the same thing. But again, he has an obstructing endobronchial lesion too. And you can see it has that typical appearance, the little tip of the iceberg, so it's jutting into the lumen and it's causing obstruction, as we saw, mostly just consolidation in the lingula with a little bit of combined atelectasis and post-obstructive pneumonia, and then some impaction in his left upper lobe bronchi. And I think that, as Jeff has pointed out before, you can see there's a subtle difference in attenuation of the lung, left versus right. So this left lung is hyperlucent, probably from the central airways obstruction. But so this one, again, differential case, and this is also a mucoepidermoid tumor, just like the one I showed a couple weeks ago. So I don't know how many of these I'd ever seen in lobar bronchi. Now I've seen 2 in young patients in the last 2 months. So minor salivary gland tumor that occasionally pops up there. All right, now here's the cool case that Jeff will like from related to my smoke and flow artifacts. And this is one that I'm going to have discussion with the clinician, because this was supposed to be presented at our cardiology conference this week, but it got deferred because the clinician taking care of this patient was not there. But this is a patient who had complications of an AFib ablation, and he had stents placed in both his left, well, this branch of, I guess, that's his left superior pulmonary vein, and then his left inferior pulmonary vein. And this was back in 2016. And you can see the left inferior pulmonary vein stent is wide open. Left superior pulmonary vein stent has had some issues. And even here, I think there's a little less attenuation than there is in his left inferior one. But this was back in April of 2016. Then he goes to an outside hospital in August of 2016. And of course, here's our friend smoke here in the pulmonary artery here. And you can see we're early. This is very ill-defined. And also notice where it is located. There's a little bit that creeps into the left lower lobe, but it's largely in the left upper lobe, as you see right here. And when you look at the stents, you can see that the left inferior pulmonary vein stent is open, but the left pulmonary vein stent is either severely stenosed or occluded. And so this was done at an outside hospital, and he was diagnosed with pulmonary embolism based on this study. And I think based on all the cases we've seen, the other factors here, how early we are in the scanning, the fact that he has a downstream obstruction affecting that area, we would argue that that's probably not the case, except that he's had, and these have all been at the outside study, next year has symptoms still, same finding, different appearance, but same distribution. And this superior pulmonary vein stent is still occluded. The inferior one is still open. We still have early scanning with this, our smoke confined to this area. And then he had another study just this past month. And so this is in part, he was being referred for management of his presumed chronic PE in addition to his occluded stent. So I'm trying to get them now to just do a repeat with delayed imaging to show that this is really just slow flow here. But as the case Jeff recently showed, and as we've discussed and Seth was mentioning, when when you see it, well, if you see it in the pulmonary vein, it can always be a clue to the chronic thromboembolic disease or regional pulmonary vascular inflow stenosis. And in this case, it's just outflow obstruction causing just congestion more proximally. So yeah, I'm hoping that we can get this patient back and just put this to rest with some delayed imaging. So again, always beware, especially when you've got this early timing like this. All right, now this is kind of funny. This patient had radiographs, and this was at the VA, and I actually read both of these radiographs. And it's a lady, this is the one in October, and I don't know what I was thinking back in October, because I saw that there was some nodular stuff. You can see there's some peripheral nodules here, and I'll blow up just this one to show you. And the lungs just look a little bit busy, and for some reason at this time, maybe it's because I didn't have the full history, but I was thinking maybe this was going to be some sort of chronic mycobacterial infection, or some sort of viral infection or small airways infection. And I'll show you the follow-up, because I didn't even realize, and this goes to show that sometimes there's even there's intra-observer variability, because I looked at this one about the end of last month, and when I was looking at it with the resident, I was like, wow, this looks like a radiograph that would be good for Langerhans cell histiocytosis. And then I looked back and saw my old report, and I was like, what the heck was I thinking? Because here you can see there are a little more nodules, and now looking at it, I think they're more upper lobe predominant, and in fact spare, as we would expect, the areas in the lower lobes. And so I had to, disagree with myself. And we did get the CT. We called the clinician because she was an outpatient. She was a big smoker. And you'll see, unfortunately, they did thick slices at the outside, but here we can see some bizarre cysts, some small little ill-defined nodules. And I think that we would all support the diagnosis of Langerhans in this case. As you go down, you see the inferior portions of the lingula and the lower lobes are clearly spared. And for whatever reason, I don't know why a lot of places do this, but the coronals and the sagittals are actually thinner reconstructions than the axials are. Yeah, because I think you can see here that there's some little bizarre shaped cysts with nodules in a smoker with upper lobe distribution. And actually, this CT at the outside hospital, they had said that she had probably had metastatic disease. So she was relieved to hear from us that this is Langerhans cell histiocytosis. So she just needs to stop smoking here.
Yep.
But yeah, and I think this may be the last one that I have locked and loaded. And I'll give you a second to look at this because I think this is a fantastic radiograph. It's a young patient, and I'm sure Howard and Jeff have jumped to the abnormality here. But you can see that there's this retrocardiac abnormality. And then as you zoom in, unfortunately, I don't have a lateral here. You can see it looks like it's lifting the paravertebral interface here. And also, I think the bonus finding is if you really zoom in, you can see that the vertebral body at this height where this is centered is is loosened and certainly lost height asymmetrically on this side.
Yes.
Now, this other vertebral body, because normally we'd think about discitis osteomyelitis, which should be more of a disc-centered process. I think both of the other vertebral bodies look reasonable. It looks like it's centered at this level. And so she ended up undergoing a further evaluation. I don't actually have a CT on her, but this is the MR, and you can see that she's got this big destructive lesion at this level. I don't remember how old she is, but this actually turned out to be, I think she was, 28. So she was not in her teens, she was in her late 20s. This turned out to be a Ewing sarcoma isolated to the vertebral body. And you can see there's a little bit of impingement on the central canal, but they went in and did a corpectomy and a reconstruction of her infusion of her spine. But I think it's just a great radiograph showing a paravertebral and vertebral abnormality here.
Can you show the chest radiograph again one more time, just at the default window width setting, not zoomed?
Oops. Yeah.
I did see that, but I also wondered for a moment whether the right lung is loosened compared to the left, or suffice it to say there seems to be an optical density difference between them. But then when I look at the soft tissues, I think it extends to involve the soft tissues as well. So I think it's a real phenomenon, that is, there is across the chest, left to right or right to left, an attenuation difference, maybe a form of grid cutoff or in some fashion.
Yeah, some grid decentering or something like that.
Yeah, exactly. I think if you put region of interest even on the soft tissues of the axilla, I think you're going to get differences. So I think it's a technical phenomenon, and somehow there has been some form of grid cutoff or decentering, so that the attenuation difference also involves not just apparently the lungs, but the chest in general, I think.
Yeah, there's more than a 10% difference here. That's a good observation.
Yeah, because for a second I was trying to connect the two findings, but I wasn't able to. Okay, that's interesting. Wow. Okay.
All
so
right.
Ewing's involved in the wound.
I don't.
Yeah, Howard, that's all my cases for here. So.
All right. Well, I think we'll end a little early today, but thanks for all the good cases, and we'll hopefully meet again next week. Talk to you later.
All right. Thanks, everyone.
Bye.